Today, we dive into the evolving landscape of cardiac arrhythmia care, spotlighting advanced approaches that are reshaping electrophysiology and surgical collaboration. We'll explore together expert voices from both sides of the table, electrophysiologists and cardiothoracic surgeons, to discuss the nuances of hybrid procedures, procedural decision-making, and interdisciplinary synergy. We'll also explore a transformative role of artificial intelligence, machine learning, emerging digital technologies in enhancing precision, outcomes, and patient care.
Welcome to Baptist Health Doc to Doc, a podcast built for innovation and collaboration by physicians for physicians.
Hello, I'm Dr. Tom Nguyen, a cardiac surgeon and chief medical executive at Baptist Health Miami Cardiac and Vascular Institute. Joining us is Dr. Pascual, electrophysiologist at Baptist Health Miami Cardiac and Vascular Institute, with extensive experience in managing arrhythmias, and Dr. Bryon Tompkins, cardiac surgeon at Baptist Health Miami Cardiac and Vascular Institute, focusing on structural heart treatments and collaborating on rhythm disorders. Thanks for joining us, Dr. Pascual and Dr. Tompkins. For the physicians out there, can you describe to us what are some typical disease processes that electrophysiologists and surgeons that are involved in that space might end up treating?
Yeah. Thanks for having me, Dr. Nguyen. It's always exciting to be here and talk, with some colleagues, especially ones we work so closely with. So I appreciate your time and having us on board. So electrophysiologists are essentially doctors of heart rhythm disorders. As most know, there'll be different portions of the heart. There's the structural portion, the coronary artery disease or obstructive disease, and what we specialize is in heart rhythm disorders. So most common arrhythmia in this country and worldwide will definitely be atrial fibrillation. And so that'll be the most common arrhythmia that we treat. And, the treatment of atrial fibrillation has certainly gone through an evolution, especially in the last 20 years. And that evolution has been combined with CT surgery collaboration. And as we kind of move into the next stage, different forms of energy that we're using in order to treat AFib. So definitely an exciting time for EP, especially in the space of atrial fibrillation.
Can you describe a typical process that you treat, but most physicians might not realize that you treat?
Yeah.
Maybe a untreated population that needs to be treated that most people might not be as aware of.
I think there's several in the EP space. And one would be the early referral of atrial fibrillation. We many times see a very late referral, patient that's been in atrial fibrillation for many years, and we know our outcomes are just not good enough. So getting that early referral is extremely important to have the best outcome for that patient. And secondly, our PVCs. I think premature ventricular contractions are something that are severely undertreated in our community. We have many patients that are suffering either from cardiomyopathies due to PVCs or that are highly symptomatic from PVCs. Yet once again, there's a little bit of delay in diagnosis of what's causing this patient's symptoms, and therefore they're not seeking the correct care with an electrophysiologist early on enough.
I'll add to that. Thank you. Thank you for having me again.
Yeah, of course. Thanks for joining us.
Just to kind of bounce off what he was saying, because he's absolutely right. AFib is really the number one thing that we do treat surgically. And we've come a long way from the cut and sew maze that Jim Cox taught us way back when, where we would actually open the heart and actually make lines and incisions in the heart itself and then sewing them back up. It took hours. It worked very well. But, today's day and age, like Dr. Pascual mentioned, we now have newer energy devices. We do cryoablation, we do thermal ablation. A lot of AFib actually begets AFib, which means it gets worse and worse. And therefore, as that left atrium starts to dilate, it can also affect valves like typically the mitral valve. The mitral valve itself can induce atrial fibrillation. So as surgeons, we have found that we try to do a concomitant procedure if we're referred for a valve. Even for coronary work, if we're referred for a valve and we're there looking at the mitral valve, we're going to cryoablate. And we've found that if we can get people back into sinus rhythm, it actually improves their EF significantly through many surgical trials, from 40% upwards to 55% post-op. And then furthermore, to take it one step further, since we've been doing that in a concomitant space, now as a surgical ablation, for people who have longstanding persistent AFib, as you can imagine, as that left atrium dilates, more scar forms, more micro reentrant patterns start to form, and it becomes harder for the electrophysiologist just to tackle it by themselves. So therefore, we as surgeons do minimally invasive procedures where we can go behind the heart and ablate it and also tackle the appendage while we're there as well, so we can get them off of anticoagulation, get them off of chemicals. And then one last thing I was going to say was that we also as he was kind of mentioning, the PVCs, we do intractable VTAC. People will do sympathectomies for that as well. And we also help them in that sense as well.
Can you both give us an idea of really the disease burden? You know, how many patients out there are afflicted by this? And then just concrete, tangible results of it being treated, you know, maybe a mortality, a morbidity, you know, feeling better, but just something that we can better understand. Why do this? How big is the disease process, and why even do this to begin with?
Sure, absolutely. It's a great question. And, you know, we say AFib is an epidemic, and there's many reasons for that. But if you look at the prevalence of AFib, there was in 2010 probably about 2 to 3 million people in the United States with atrial fibrillation. That has exponentially grown to the point where by 2030, we expect about 13 to 14 million patients with atrial fibrillation in the United States. So it's just this epidemic growth. Reasons for that are multifactorial. You know, there's definitely an obesity epidemic. We're learning that there's more and more of a genetic input or causes of atrial fibrillation. And so as obesity rates grow, diabetes grows, the incidence of AFib. There's also some good reasons. You know, patients with structural heart disease and patients with any type of cardiovascular disease are living longer, and age is definitely one of the main predictors. So if we look at incidence or prevalence in patients that are younger than 55, only 0.2% of the population will have AFib. But once you hit the age of 80, 85, that prevalence goes up to about 10 to 12%. So age is definitely a huge predictor of atrial fibrillation. We always say in terms of outcomes that the earlier we see atrial fibrillation, the better. And it's once again talking about that disease process. Early on in the disease process, we know that AFib is predominantly isolated to the pulmonary veins and triggers in the pulmonary veins. So if we were, you know, get a patient with AFib and kind of slice their heart, we can visualize these little diamond-shaped structures, what we call myocardial sleeves, that sit inside of these veins. That will be the main trigger for atrial fibrillation. So at first, when a patient is paroxysmal in atrial fibrillation, the procedure is quite simple. We can go in, we isolate the veins, we eliminate these triggers with different energies, which we can speak of later, and we have success rates of about 90% of these patients. As that disease progresses and they become more persistent, meaning longer than 7 days, or long-standing persistent, more than 1 year, then things really start to change, because it's not just isolated to the pulmonary veins, but now the atrium itself is changing. There's a lot more fibrosis. There's upregulation of certain genes that promote short and action potential durations of the atrium. So all these things in combination now all of a sudden makes AFib a lot more favorable, makes the areas we have to target a lot more extensive, and unfortunately really makes outcomes much worse. So when we're thinking about AFib or persistent AFib, outcomes are about 70% success out to 5 years. So we have a drop from 90% to 70% just because there may have been a little delay in the referral, a little delay in the procedure itself. We also say that AFib management is multidisciplinary. There's a lot of trials out there. There's a beautiful trial out of Australia. It's called the Legacy trial, where they took patients and offered them ablation within the first year and then put them in a very structured program. And there was 3 different categories of these patients. The patients that lost greater than 10% of weight loss, kind of 3 to 9% and less than 3%. Those that lost over 10% of their body weight, 90% of them were in normal rhythm at 5 years. If you lost less than 3%, less than 50% were in normal sinus rhythm. So just pushing that multidisciplinary approach, with our colleagues to really manage AFib aggressively.
Now, I want to emphasize a couple of points to take home is that with a lot of disease processes, the earlier we treat, the better. And if we wait too long, it's going to be a lot harder to treat. So with AFib and a lot of other rhythm disorders, it's so important for physicians to send the patients in early. And I think that's a potential untreated population. But can you both elaborate on why patients aren't coming in? Is it awareness? Is it the patients aren't feeling it? What can we do to help capture those early patients when they have that early disease to bring them in?
I think, if I don't mind, a couple of things. As he was mentioning that, unfortunately, people may not feel anything. Number one. Number two, they may feel it and not know why they feel crummy. And then number three, there was the age-old paradigm of maybe we should just treat this with antiarrhythmics, get their heart rate normalized under 100 and, maybe put them on some Eliquis and they'll be fine. And, a lot of times you'll follow people out and they're doing okay. But again, maybe their EF's dropping, maybe the left atrium's still dilating, maybe the mitral valve gets worse, and maybe we don't get an echo on time. And so for that particular reason, people who are in AFib, now that we've found, as I mentioned before, that if we get them back into sinus rhythm, they A, feel better, B, reduce their incidence of stroke, and then C, their ejection fraction comes up. So therefore, their risk of mortality goes down. And as Dr. Pascual was saying, a lot of these people are referred late, meaning probably more than 70% or so are no longer paroxysmal when they see an electrophysiologist. From a surgical perspective, we have a few trials like the CSAF trial or the Converge trial that has shown that although it's really hard to maybe tackle these patients from an endovascular standpoint alone, when you add a surgical ablation from the epicardium, you can get kind of back to the 80 to 90% success rate out to 18 months. And again, getting these people off of chemicals and getting their appendage clipped is very important. That's why collaboration is extremely important. That's why they need to be referred early, and we can tackle this together. Furthermore, if, like he was saying, it was isolating the triggers in a paroxysmal fashion, the drivers unfortunately become more active as that atrium dilates and you get over a year or so. And that scarring and that fibrosis really changes the whole landscape of that left atrium. So at that point, once we, from a surgical perspective, can really isolate that whole left atrial wall, and then EP as well can come back and we can map it and take a really good look to see what maybe triggers are now involved, and they also can be isolated from an endovascular standpoint, we can really tackle this together in a holistic fashion, I think.
Yeah. So again, so important. If you have patients with rhythm disorders, earlier is better. And if we get the patients there, we can treat them. Let's talk about the consequences a little bit. So one of the consequences is possibly decreased ejection fraction, heart function. The other is stroke as well. Yeah. Maybe let's talk about that and what are ways we can maybe manage and minimize the risk of patient having a stroke after if they have atrial fibrillation or some other rhythm disorder. Yeah.
And I think this is a pretty complex question that we like to really simplify. I think a lot of physicians and certainly patients think that if the atrium is fibrillating, then that's when their risk of stroke goes up. And unfortunately, it's a lot more complex than that, than we know. There's a triad out there that everybody knows pretty well that promotes, thrombus formation. And the same lies true in AFib. It's not simply a fibrillating atrium that causes stroke, but you have to have the correct circumstances for it. We know patients that with AFib have, kind of inflammatory cytokines that make them prothrombotic. We know they have some endocardial dysfunction, and they have this little outpouching called the left atrial appendage that kind of gives the perfect nidus for thrombus formation because the sluggish flow, the endocardial disruption within the appendage, and just that prothrombotic state. Mm-hmm. So the best thing we can do for our AFib patients, I always say, is minimize the risk of stroke. Right now, we have a risk calculator called the CHADS-VASc score, which it's good. I mean, it's the best that we have, and I think it certainly is doing a good job in preventing stroke in our patients. But I think it's not specific enough. And I think if we sat down in another 5 years and had this same discussion, I bet we're going to have something better than the CHADS-VASc score, something that's much more specific. But for the time being, it's what we have. It's a risk profile. If that CHADS-VASc score is greater than 2, we know that patient's risk of stroke is greater than 2% per year. And at that point, it's always recommended to start anticoagulation, most likely with direct oral anticoagulant nowadays. Direct oral anticoagulants are fantastic. They work really well. But we know that up to 25% of patients, after taking a direct oral anticoagulant, will stop it within a year. And there's many reasons for that. I think once you tell patients they're going to take a blood thinner, they get very anxious about it. in United States healthcare, these medications are extremely expensive. And, at the end of the day, it's hard to take a medication every single day. So adherence to medicines is also certainly an issue.
So that's a great point. So, stroke is one of these things that people fear more than death sometimes. Yeah. It's very debilitating. And whatever we can do to minimize that risk of stroke, I think is important. But in some patients who have AFib, atrial fibrillation, they don't want to be on a blood thinner. And there are things that we can maybe do to avoid them having to be on an anticoagulant, even though they have atrial fibrillation. Can you talk a little bit more about percutaneous options and possibly surgical options for managing, the infamous left atrial appendage as you're alluding to?
Yeah, absolutely. And it's funny. I do a lot of different procedures, but when you talk to a patient about a way to get off anticoagulation, they'll be the biggest smiles that you'll receive all day. So I love it just for that reason. It's a huge patient satisfier. It truly is. And there's different options. There's the Watchman device. There's the surgical clips. There's multiple other percutaneous approaches that are coming out in the future as well that we're involved in research with at Baptist Health Miami Cardiac and Vascular Institute. But they essentially have the same principle. That left atrial appendage, that nidus where you have blood stasis and it's a blind loop of blood flow, you're using some type of percutaneous approach to seal off communication between the left atrial appendage and the atrium. So we're getting access in the groin, going up, doing a transeptal puncture, and usually either guided by some type of echocardiography, we're placing some type of plug within the appendage in order to minimize the communication. The beauty of that, it's percutaneous, the recovery is quite quick. But the left atrial appendage can also be a trigger for atrial fibrillation. And we know that with our percutaneous devices, unfortunately, we don't cause electrical isolation of the appendage. So it's one of the limitations of percutaneous left atrial appendage occlusion devices. And that's where kind of hand it off to Dr. Tompkins so he can discuss the beauty of that surgical clip, that atrial clip.
Yeah, if you could expand, Dr. Tompkins, in what scenarios would a Watchman device or other devices out there be a good ideal solution? And in what scenario would a surgical approach to ligate the left atrial appendage be a better solution? And describe briefly on how you would do that.
Yeah, sure. So number one, anybody who another issue is if you can't tolerate anticoagulation. So if you can't tolerate anticoagulation, an endovascular approach is not going to work merely because they have to still be on anticoagulation for a short period of time after they get it occluded. From a surgical perspective, number one, if we're going in there for pericardial effusion to be drained, number two, if we're going in there because someone has persistent AFib and we're treating the posterior wall and we're looking right at the appendage, we can clip it. Number three, if we're going to go do a concomitant procedure, meaning if somebody's already coming in with a valve disorder and we're going to ablate them, with a cryoablation or radiofrequency ablation, whatever, that we can also not only put a clip there, we can also cut the appendage, we can sew the appendage off. And furthermore, while we're doing it, just like our EP colleagues do the same thing, we're using a TE, we're using an echo to make sure from many different angles that appendage is completely occluded, because the last thing you want is any gap at all, because then that's another nidus for possible thrombus, which we want to stay away from. From a surgical perspective, when we're doing this minimally invasive, like a convergent procedure, we're able to make little tiny small incisions in the chest, and through a thoracoscopic approach, we'll open up the pericardium. The appendage will pretty much pop out towards us, and we'll put a clip directly across it. It doesn't take much time at all. Like I said, it's going to be under TE guidance. And once that's done, it's very minimal pain associated with that.
Before we change gears and talk away from AFib a little bit, let's talk about the flip side where your heart rate gets really slow. And that's something that I believe you all treat as well. So maybe describe the conditions that are often treated when you have a slow heart rate and how it's done. And maybe potentially the unmet need there too, where there are patients out there who probably need it done, but they don't know they need it done.
Yeah, definitely. So, AFib can also present with other bradyarrhythmia disorder. It can definitely have a tachycardia component, but it can have, tachybrady syndrome is actually something that's extremely common. So patients will be in AFib and they'll go quite fast, and then all of a sudden they'll convert to sinus rhythm, and their sinus node just has a little bit of disease. So they'll have what's called sick sinus syndrome. And so those patients can sometimes be difficult to treat because they're extremely fast in atrial fibrillation, but on conversion back to sinus, all of a a sudden they're extremely slow. In these patients, we always consider two options, and I think it depends on the profile of the patient. But there's either an ablation, which can have a really good chance to prevent that tachycardia, so you just can live with a little bit of sinus brady, or there's pacemakers that we can use in order to treat those brady arrhythmias, maybe the safer approach. Pacemakers are minimally invasive procedures nowadays. There's two types of pacemakers out there now. There's a traditional or the transvenous lead, so getting access in the axillary vein, passing leads into the heart, or there are what we call leadless pacemakers out there nowadays. So the limitations of transvenous devices is that, no lead will last forever. So usually with the pacing leads 25, 30 years down the road, at some point you're going to have to start thinking extraction because, the leads are moving with the heart. So they're moving and contracting 60 times a minute. Over 20, 30 years, those leads can definitely start to fracture, have issues with them. Device infections can also be, a big problem in our patients, about 2% per year. And so that's one of the reasons that leadless pacemakers have really, caught a lot of attention. We think, the risk of infection is much less than 1%. So it's extremely rare. And it's a lot more comfortable to the patient. They don't have a pocket. They don't have arm restrictions after the pacemaker, something they definitely appreciate. So it's definitely an evolving field. There is now a type of pacemaker that's called conduction system pacing. So with pacemakers in the past, something we wrote about, if you cause chronic RV pacing, you cause a lot of dyssynchrony of activation between the right ventricle and the left ventricle. And up to 20% of these patients would, start to establish some heart failure. Now with conduction system pacing, we have a specific lead that can bury itself deep into the septum and actually capture the left bundle. And so if you're capturing the left bundle, you're pacing the native conduction system of the heart. And so you get these beautiful narrow QRS results, and you essentially eliminate the risk of developing a, dysynchronous heart and heart failure from chronic RV pacing. So definitely, pacemakers are something that were just so flat and stable for, many years, 30 years. And all of a sudden now we have leadless pacemakers, we have conduction system pacing, we have advancement in biventricular pacing. And it's just been, become very, very exciting as well lately.
Just to add one thing to what he said, because the one interesting thing is that these pacemakers have been there for a while, and they're going to be there for a while, even after we have all these minimally invasive procedures that we can put in there. Because the point I wanted to bring up was, if you see someone with a blood infection at all and they have a pacer and they have leads in there, they have to come out. That is a class 1 indication to remove them. Then we can go in and put another type of pacemaker if the patient has the anatomy for it or has the physiology for it. But it's very important that everyone's aware that, if someone has a bloodstream infection and they happen to have a pacer and a pacing lead in there, it should come out, and we should contact us both for us to take care of that. And furthermore, we also try not to leave too many leads in there, because guess what? You're going to end up causing fibrosis, and then you're going to have obstruction in the future. You can have another issue. Yeah. So just a sidebar to what you were saying, because I think it's important that everybody knows about these possible issues that can arise in the future.
Yeah, I think that's a great point, Dr. Tompkins. Many times we'll see patients that are almost placed on 6 weeks of antibiotics, hoping the infection goes away when they have indwelling devices, and it will never go away, right? The Staph aureus forms that biofilm, Streptococcus can form that biofilm, and as soon as the antibiotics are removed, the bloodstream infection comes right back, and those patients get quickly septic. So it's a great point. Total system extraction is definitely the standard of care in these patients.
And Duke actually just did a study that says that if you can extract these patients less than 6 days after they have a bloodstream infection, their risk of mortality goes down. So therefore they live longer. So that's also very important for them to know and get transferred to us as a center to be able to do this.
What makes Baptist electrophysiology program different than others? What makes us special?
Yeah, I think a couple of things. I think number one is our focus on outcomes. If we look at, as an EP group, when I sit down with my partners with Dr. Villas and Dr. Woner, the first thing we're looking at is our outcomes and how are we doing in regards to comparison to national benchmarks. And it's something that we take a lot of pride in because I think we beat a lot of those national benchmarks. And so it's definitely something we're very proud of. I think we're also, Miami Cardiac and Vascular Institute has a word of innovation, and that started from, the legend of Dr. Barry Katzen. And I think at, Miami Cardiac and Vascular Institute, we're always pushing for innovation. So we're always looking to see where the field is going, where it's going next, and trying to really push those limits to really optimize the care of our patients. So I think those are the two main things that drive our program. We also believe in ease of access. So we always say that there should always be room for our patients to be seen electrophysiology within the first week of getting the call. And so it's something we put a lot of focus on when we review our data at the end of each month.
Well, I can attest to that because every time I reached out to you all, you see the patient promptly and the patient is very happy and there's very little delay.
Great. I'm glad to hear that.
Dr. Tompkins, what makes Baptist EP different?
So I would say that our collaboration, our ability that we reach out to, just us being here today will tell you that, from a testament from a surgical side, from the EP side, that we collaborate together. And furthermore, there's many other different people that we collaborate with, So I think that's number one, important. Number two, that we see our patients quickly. And really number three is not our outcomes are absolutely important, but what makes our outcomes important also is what brings patients here is it makes them happy. So we want you to be happy. Not only that you're happy because you got a good, durable, lasting outcome.
How do we get patients to you? Describe to us the referral process.
Yeah. So we have a main centralized number that you can certainly call, and we will call that number back within 24 hours if it's not immediately, especially if it's after hours. We also have an email that we can certainly, give out. So if we email the patient information, there's somebody on the other side of that will call out and reach out to the patient. And I always say, to the physicians out there, my number is essentially a public number out there. Feel free to send me a text, send me an email, and I'll definitely help arrange that visit.
Great,
the number would be 786-204-4201 for our centralized number if anybody wants it.
Thank you. Dr. Tompkins, anything else to add?
No, similarly, and not only that, but we have boots on the floor 24/7 at South Miami and at Baptist. So anytime you need to get a hold of one of us, one of our APPs will be there and available to answer that phone call, then call us. And again, the same thing that we're also very much available through our phone number and our email as well. So MCVI is ready and open and available to you at any point in time.
As you wrap up, I was hoping each of you can give some final comments and thoughts on the program here and the direction of the program as we conclude.
Sure.
Yeah. I think, Tom, we've talked about it. We're very excited about EP at Baptist South Miami Cardiac and Vascular Institute. I think we're staged for growth. And, we see that we can make a huge impact in our community. As we discussed earlier today, there's definitely room for earlier patient access into our office. If we look at the, number of AFibs done in Miami-Dade County, it's actually below the national benchmarks. So there's definitely, a lot of excitement for growth within our community and, not just from a physician standpoint, but also a patient standpoint to kind of improve the access to our EP clinics.
Dr. Tompkins.
From our standpoint, we're also moving forward in the world of AI as well. I think is actually very important. We're introducing robotic approaches to ablate the left atrium, and why is that important? Well, because once you introduce an AI system, for a couple of different reasons. Number one, it keeps you out of harm. It can map the heart better and make sure that you're getting and isolating those abnormal electrical impulses, and then furthermore, just to another step further for your cardiologist or an internist who's getting an EKG, there's going to be AI models, and there already are AI models that have EKGs that may read to the eye normal, but AFib or any other arrhythmia may be buried deep in that. And I think that's where it needs to be explored. That's where they need to come to us. That's where they could come to him and get maybe a loop recorder or something involved to make sure that we're capturing this early.
Mm-hmm.
I want to thank you both for joining us this afternoon to talk about something that's really important. Dr. Pascual, Dr. Tompkins, and I want to thank the audience for joining us today. I think there are several really important take-home points. The first is that rhythm disorders is very prevalent across our community, especially here in Miami, but is really undertreated. We know that Florida in general is a state that's growing, but in population that's aging. And those are the patient population that tend to have these rhythm disorders. And we know a lot of them aren't being treated. And the earlier we treat them, the better. The second is that the consequence is important. You can have decreased heart function, you have a risk of stroke, and we can treat those as well. A lot of different technologies to treat that here at Baptist. The third is the collaboration that we have with electrophysiologists, surgeons, but also the collaboration with industry and technologies out there that give us access to different toys that a lot of other folks might not have access to. And then last point is that as a program here, we are readily available. The service side, if you want to send us patients, we have a number that you can call. You can even call Dr. Pascual's mobile home number anytime you want. He'll be there and he'll answer it. But we're really here to serve our patient community and take care of patients out there with rhythm disorders. So thanks for joining us, and hopefully you'll join us next time. Thank you again.
Thank you.
Thank you very much.
Thank you.
It's fun. Great. Thank you.
To find out more about the topics covered on Baptist Health Doc to Doc, please visit physicianresources.baptisthealth.net.